Hello, everyone, and welcome to another Rush Generations Health Education Lecture. Rush Generations and our staff is delighted to be your source of information, resources, and health promotion programs that help maximize your well-being and good health as you age. Today is Wednesday, March 19. I'm Grisel Rodriguez Morales, Rush Generations Program Director. I'll be your moderator for today's talk. It's a Women's Health Roundtable, excuse me, where we'll be exploring or discussing health strategies that empower women to maintain and possibly optimize their well-being or our well-being and health so that we can continue to engage in the activities that matter most to us. Before I present to you the wonderful panelists joining us today, I'd like to first thank our producer, Hannah Weitzman, helping us, as always, manage the chat. So if you have any questions, please do so. Hannah will be helping us manage the chat and other key aspects so that we can all have a great discussion about women's health in our later years. As always, we're live streaming this lecture via our YouTube channel using this video platform Zoom, which allowed us to also host a good number of people who join us via phone. So thank you so much for joining us. For those of you on YouTube, please use the chat function to ask questions or to add to the discussion throughout the lecture. We will make sure that your comments and the questions make it to the presenters. And for those of you listening, remember, you always have an opportunity at the end to unmute your audio so that you can ask your questions as well. So we'll try to do that. The format today is slightly different, but trust us, all of you will have a chance to participate. We like to remind you that all information that is offered here is usually for general informational purposes only. If you have any situation that is very specific to you, we'll try to answer, but we always encourage you to seek additional professional advice so that is very specific to what you need. Okay, so wonderful panel, look at this. Let me start by introducing Dr. Robin Drake, who is a board-certified obstetrician gynecologist with 13 years of post-residency clinical experience. She is an assistant professor of OBGYN at Rush University Medical Center, where she has worked for the past 4 years and a half. And in addition, she's the director of DEI for the OBGYN department and served as the assistant clerkship director. She cares for patients from adolescence to post-menopause and enjoys building lasting relationships with her patients. Her career interests include reproductive health, health equity, and medical education. No wonder you are with us at Rush University Medical Center. Then we'll hear from Dr. Caroline Turkelson and Dr. Catherine Marino. Dr. Caroline Turkelson is an adjunct associate professor at the University of Minnesota, and she has worked at the Women's Health Clinic for 2 decades, providing holistic, integrative women's health care. She retired from clinical practice in early 2020 to write and consult on women's health issues. And Dr. Marino is a professor emerita of the DePaul University and has dedicated her career to mentoring women in their educational and life pursuits. Dr. Marino teaches, writes, and consults on neuroscience and learning and on various aspects of women and aging. She is the co-founder and co-host of the weekly podcast, Women Over 70, Aging Reimagined. And actually, Dr. Turkelson and Dr. Marino are the co-authors of Beyond Menopause, The New Ways to Holistic Health, which was published in 2023. And then we'll have another Rush practitioner, Dr. Annabelle Santos Volkman, who is the co-founder and serve as the medical director of the Rush the Rush Heart Center for Women for 20 years. She is the Macmillan Abel Professor of Excellence in Clinical Cardiology at Rush and a nationally recognized leader in cardiology care and research. She is the Chief of Research and Academic Affairs in the Division of Cardiology. And Dr. Volkman has received many awards from Rush University, the American Heart Association, Women Heart, and other national organizations. She has consistently, since 2006, been recognized in Chicago's Magazine's annual list of top doctors. It is with great pleasure that we introduce this wonderful panel to you. I think we're going to start with Dr. Drake, if you would like to join us. Wonderful.
Hello, thank you so much for the great introduction and for having me today.
Our pleasure.
I believe Hannah has my slides to start here.
They're coming up. Thank you, Hannah.
So as I mentioned in my introduction, I am a board-certified obstetrician gynecologist. Been working for about 13 years and have been at Rush for about 5 years. You move to the next slide. So thinking about obstetrics and gynecology, a lot of people just think about, oh, we need to go in to get our pap smears. But there's a lot more that your obstetrician gynecologist does for you and can do for you. We typically work alongside primary care physicians to provide broad integrated care throughout the lifespan. So we do focus a lot on preventative counseling, health education, and we see patients from adolescence, sometimes even earlier than that, through reproductive years, pregnancies, menopause, postmenopause. And our goal really is to advance community-based health for women and those assigned female at birth at all ages. Next slide. So typically we recommend that women and those assigned female at birth start seeing a gynecologist by age 21. Though if there are, patients that have other concerns, menstrual cycles, pelvic pain, things like that, we even see people younger than that. So thinking about family members that might need to see us as well. And we typically recommend a yearly gynecologic visit through at least age 65. Typically over age 65, if someone is low risk, it's a discussion with your provider as to whether to continue outpatient gynecologic visits. And if you're low risk, typically we see you every 2 years after age 65. But thinking about some reasons that you might want to see your gynecologist outside of just those routine visits. So any vaginal bleeding outside of after menopause, we would consider something that we need to investigate. One of the biggest reasons is that some of the gynecologic cancers, so things like uterine cancer, cervical cancer, often present with abnormal bleeding. And so if you do have any bleeding, even spotting outside of after your periods have stopped, we do want to evaluate that to make sure we're not missing something and that we can catch something very early if we are. Other symptoms that you might experience that we'd want to see you for would be things like vaginal dryness, sexual dysfunction, decreased libido. And as estrogen levels drop after menopause, that can cause some of these symptoms, but it can also lead to things like more frequent vaginal and urinary tract infections. Other reasons you might see the gynecologist outside of those routine visits would be things like having pelvic organ prolapse. So potentially the uterus is falling, where we can see potentially the cervix is coming close to the opening of the vagina. Sometimes that can cause pelvic pressure, discomfort, even bleeding, sexual dysfunction. And then some of the symptoms related to menopause, things like hot flashes, mood changes, sleep disturbances, those might be a reason to see your gynecologist. and then discussing if some of those symptoms are indications for you to be on hormone replacement therapy and to manage that. Additionally, gynecologists can manage things like bone loss that happens after menopause. So things like treating osteopenia and osteoporosis. Or also can evaluate breast abnormalities. So getting a regular breast exam in addition to ordering your routine mammography are things that we can help with and support. And then up through age 65, we do recommend still getting regular pap smears. Those guidelines have changed significantly over time. So we do have patients that recall, the every year pap smear, and that's not our recommendation anymore. Our recommendation, if you've had normal pap smears throughout your life, is that we also screen for HPV. And if both the cells of the cervix and perhaps in the HPV or human papillomavirus are normal, then we can extend screening typically up to 5 years for people. While that's the recommendation, we do still want to see people on an annual basis. And seeing that we have this list of things that we could see you for outside of pap smears, just reminding people that pap smears really only screen for precancer or cancer of the cervix. So they don't screen for anything else. And that's why those recommendations you have been changed, that we know that if someone's had a normal pap smear and negative HPV, their risk of having a precancer or a cervical cancer is exceedingly low in those upcoming years. With that said, too, if you've had normal screening and we've had a good 10 years up to age 65 that you've been screened regularly every few years with your pap smears, we can stop screening at age 65 for most women. However, if you did have abnormal pap smears and you had things like a precancer or what we consider high-grade lesion of the cervix, then we recommend screening past age 65. And so that's an important thing to discuss with your providers too. If you've had abnormal pap smears, we may need to screen you up to 25 years past that last abnormality. And so that might have people still screened into their 70s and 80s, depending on what the pap smear results were. Next slide. And the other thing to kind of consider and some of our other experts today are going to talk about some of the sequelae of this or the results of this. Some of the things that happen earlier in our reproductive lives surrounding things like pregnancy or medications or periods, those can affect your postmenopausal life as well. Things like birth control use in the past actually has some benefits that might last into your 50s, 60s, 70s. So there can be some cancer reduction that happen from taking things like birth control pills. We know that years of use of birth control can decrease your long-term risk of things like colon cancer, ovarian cancer, and uterine cancer. However, it might also slightly increase your risk of other cancers like breast cancer and cervical cancer. So reviewing some of your past health and reproductive health with your providers can help us kind of assess what your future risk might be as well. Next slide. Right, and then other things that might occur, like things in pregnancy, as far as things like diabetes in pregnancy, can then later increase your risk of type 2 diabetes. Same thing with blood pressure disorders in pregnancy, like preeclampsia and high blood pressure. Those can have some longstanding effects on your cardiovascular health. And so it is important for your providers to know things that happened in your reproductive time as well. If you did have preeclampsia or high blood pressure, you are at increased risk of having high blood pressure later in life, having increased risk of things like heart attack, stroke, and congestive heart disease, as well as peripheral artery disease or clogged arteries. So it is helpful to kind of review what's happened in the past so that we know how to assess your risk for the future. So I am very excited to hear from our expert cardiologist today about women's health as well, cardiac health. And that was kind of biggest points I had today, just seeing how we can support your health kind of throughout your reproductive health, but also to postmenopause. And if anyone is looking for obstetrical services, please reach out to us. There's your scheduling information as well. Thank you.
It's easier to hear me if I'm unmuted. So thank you for that overview. And we have already a couple of questions, but let's then we can bring in Dr. Torkelson and Marino, and then we can address those questions if you don't mind. Let's see, let me help with, okay, good. Here you are, and Dr. Marino. There you go.
Well,
you're gonna go first?
Sure, I will go first. Hello,
I see.
Is that fine? All right. So, well, thank you for the invitation to be on this panel to offer our perspectives of how health span for the postmenopausal women can be optimized. Catherine, who is also on screen here, is a professor emerita from DePaul University, and I am a retired women's health physician from the University of Minnesota. Now, Catherine and I co-authored the book called Beyond Menopause, New Pathways to Holistic Health. We wrote this book because we wanted to highlight the unique healthcare needs of postmenopausal women as they age. Postmenopausal women are a growing population of women who have transitioned beyond menopause. And there is actually over 55 million of us in the United States. Many of us have 30 to 50 years to live and desire a healthy and active life. That is why the concept called health span rather than lifespan, focusing on the number of years a woman remains free of significant illness or disease, rather than the years lived, is so important. So I want to talk a little bit about our book because I think there's a little written about postmenopausal women. And our book focuses on ways postmenopausal women can stay healthy and active using a wellness-based, holistic, whole person approach to aging. And so what we did in our book was we divided it into 3 parts, okay? The first part of the book is about advocacy. And you might say, why would you want to talk about advocacy? Well, learning how to be your own best advocate in our current healthcare system really can be quite challenging because many of us have come from a very patriarchal health system where our voice was never part of the medical conversation. And we're trying to change that. So in the book, we offer strategies to better understand how to speak up for the health care you want and the health care you need. So the second part of the book, that is, it covers 8 different health conditions that are particularly amenable to integrative strategies that bridges the gap between conventional medicine and holistic healing approaches. These conditions that we chose for the book include the menopause transition, sexual health, sleep, anxiety, fatigue, weight concerns, bone and brain health. Each chapter illustrates different healing approaches through stories of women that I have seen over the years in my practice. And we provide a wide range of options for managing self-care. We really encourage women to utilize the 5 pillars of health as a foundation for wellness. And that includes restorative practices such as, good sleep hygiene and mindfulness practices. It's also about good nutrition and digestion, movement and exercise, emotional and psychological well-being, as well as the very importance of community connection. So in the book, again, we provide ways to incorporate these pillars into an individual's lifestyle that works for them. So then in the last section of the book, we begin to focus on self-care by nurturing self-compassion for oneself. And Catherine, my co-author, wants to say a few words about this section. Catherine? Oh, you're mute. Yeah.
Yeah. Hello, everyone. Yes, so the last chapter of the book is called Nurturing the Mature Woman. And it's a way of kind of circling back to this notion of self-advocacy. We focus on self-care. And I know that that is a term that tends to be overused. So you might think of it as self-kindness or self-compassion or as we do, self-nurturing. Because as Carolyn said, we are the ones who know ourselves, we know our bodies, we should know our bodies, and we need to be able to ask for what we need. And what we focus on in this last part of the book is the spirituality, because as we grow older, we tend to become more interested in our spiritual development, and you can define that any way that works for you. But it is that notion that we have vital force within us, and that we also are able to connect with things larger than ourselves in meaningful ways. We talk about nurturing ourselves with regard to loss, because again, loss of many kinds is another aspect of what often happens to us as we age. And we talk about nurturing our sense of purpose, however we define that as well. And we like Kristen Neff's notion of self-compassion. She's began by talking about tender self-compassion, to hold ourselves carefully and gently as we navigate life's courses. And then she changed her mind. She said, no, it's got to be more than that. We're talking about fierce self-compassion. And that's what we're advocating in this last chapter of our book, and actually the message, I think, of the whole book. Thank you.
Thank you.
Okay, I'm remembering to come off on camera, but then forgetting to mute. But thank you to both of you, Dr. Turkelson and Dr. Marino. Again, soon some questions. I like how you finish in terms of the self-compassion as we navigate all these stages. Sometimes as women, we tend to, have some messages in our heads. So we'll discuss that, but now I'm very pleased to welcome Dr. Volkman. Dr. Volkman, I was thinking of your red as well as I was seeing Dr. Marino speak. I know we know you are Rush for your colorful red always wearing, so I see a little bit of it, but thank you. Take it away.
Thank you so much. Let me just put on presentation mode. Thank you so much. As Griselle said earlier, I'm Annabelle Santos Volkman. I'm a cardiologist at Rush University Medical Center. I started the Rush Heart Center for Women over 21 years ago, and I'm happy to talk to you about your heart disease. Thank you, Dr. Drake, for introducing the concept of your heart health, especially in women who are aging, and as they get older, their risk increases. So we can talk about that as well. Just some statistics. There are 1 in 3 adult women who have some form of cardiovascular disease. So there are 33% of all women that have some form of heart disease. And women and men have similar cardiovascular risk factors, but there are some female-specific risk factors that Dr. Drake was talking about, such as the disorders of pregnancy. If you had gestational diabetes, or that you had diabetes during your pregnancy, or hypertension during your pregnancy, or preeclampsia, that increases your risk of heart disease in the future. Menopause itself has its own risk. As we get older, there's something about menopause, whether it's the lack of estrogen or other things that are going on, or as we just age, there is a higher risk of heart disease. And then women who get breast or some gynecological cancers that Dr. Drake was also talking about, that can have some implications for your heart. The treatments of those cancers can affect your heart. So those are some female-specific risk factors for heart disease. This is a chart that shows that men were considered the ones who had heart disease, and then women were told that it's a man's disease. So they worried about their men in their lives. They took care of their husbands and their fathers and their brothers, but I think they forgot to take care of their hearts. And as you can see in this chart, in 1979, there were about 30,000 more men dying of heart disease than women. But it was still the number one cause of deaths in women and men. But the men got all the attention. And so they started preventing heart disease in themselves. The doctors took care of them and very aggressively. And so we saw a decline in mortality from cardiovascular disease in men, but we started to see an increase in mortality from heart disease from 1979 to about 2000. Women were being given HRT because of studies that showed that heart disease decreased with the use of HRT. And unfortunately, the population that it helps are the young women, but older women over the age of 60 were also being put on HRT. And unfortunately, that had worse outcomes from a cardiovascular standpoint. So that by the year 2000, there were 70,000 more women dying of heart disease than men. As you can see in this chart, the decline continued for men, but it continued to increase for women until 2000. Then we found out through the Women's Health Initiative study that hormone replacement therapy in the average age of 62 had worse outcomes. They had more strokes and more heart attacks and more deaths with the use of HRT. There were also more breast cancers. So what did we do as a healthcare professionals? We increased the awareness about heart disease in women, and the American Heart Association had a symbol of the red dress. And so from then on, I have been wearing red to increase awareness about heart disease in women. And I wear red every day to remind people of that, and especially my colleagues who are mostly men. There are a lot of women cardiologists now at Rush, but there are still 80% of cardiologists are men. So we need to keep reminding them to take better care of women so that they do not dismiss them or misdiagnose them. So we studied women, we stopped using HRT in most women, and we continued to learn which population of women would benefit from them. And heart centers for women opened. Unfortunately, fortunately, that led to a decrease in mortality in women, as you can see here. But unfortunately, for both women and men, since 2015, there has been an increase in mortality from heart disease in both women and men, especially during COVID, that continued to go up. So it's still lower in women than in men, but I'm starting to get very nervous about the fact that cardiovascular disease is still the number one cause of heart disease, of mortality in men and women of all types of deaths. There are traditional risk factors, which most of us know. I'm just going to point out that diabetes is a much higher risk for women than in men. It confers a 45% higher risk for heart disease and heart attacks and deaths in women than in men. So if you have diabetes and you're a woman, you need to be really aggressively treated. And unfortunately, women don't really take their heart health very seriously. And I have to constantly emphasize to them how important treating and preventing heart disease is important to them. And then there are emerging risk factors on the left-hand side of the slide that we now recognize, especially in women, including lupus and rheumatoid arthritis. They are at much higher risk for heart disease than people who don't have lupus or rheumatoid arthritis. Women who have inflammatory bowel disease. We talked already about gestational diabetes and gestational hypertension, but people who have sleep apnea also have a higher risk for heart disease. Early menopause. If you had your menopause before the age of 40, your risk of heart disease is higher. If you have depression, that also increases your risk of heart disease. And breast cancer treatment, if you have radiation in your chest due to breast cancer, that will also increase your risk of heart disease. The best way to protect yourself is not just getting your cholesterol check or your blood pressure check, but getting a coronary artery calcium score. We offer this very easy and simple test. It's a few seconds of radiation, getting a CAT scan. We offer it for $49. Insurance companies won't pay for it, but most people can afford $49. And I always say, if you can't afford it at Rush, just let us know, and I'm sure we'll give it to you for free. You can use my name. I said that during an interview, and so far I haven't been asked to pay for it. So I'm so proud that Rush is doing that. I also want to just say that the Rush Heart Center for Women was one of the first heart center for women that was created in the United States, and the first in the Chicago area. We wrote the toolkit for the American College of Cardiology to help women cardiologists start their own heart centers for women, so that we can really decrease mortality from cardiovascular disease in women. So thank you. I'm going to stop sharing and let Griselle moderate. Thank you so much.
Thank you. And don't leave us, because now this is the fun part. We're going to invite all of you to join and get to some of the questions that we have received through YouTube channel. Sometimes my colleagues also text me a few things, so as they are trying to do the office work. And so fantastic. Let's see, Dr. Drake, if you can join us as well, that'd be great. And I realized that we might need to start with one of our colleagues. Colors. I didn't have to give the instructions. They know what to do. So they have come on mute. And would you like to ask your question? We cannot hear you. Go ahead and try again. Star 6, maybe? Are you pressing star 6? Oh, no. Well, we'll try again soon. If you have a question and you would like to ask it, please press star 6, and that will take you off mute, and then ask your question. And Dr. Volkman, thank you for your advocacy. We talked about, Dr. Turkelson was speaking precisely about the importance of us being our best advocate, which we agree absolutely, but then also being the advocate for many other women as well, the way that you do that. That's fantastic. Let's see. So I think I hear a little bit. No, I don't think that's the color. So let's go back to some of the questions. One of them came through Dr. Drake. And feel free, if you would like to throw a few comments here and there and ask questions to each other, I will love that as well. We want this part to be very dynamic. And Dr. Volkman, you also spoke about HRT, so the hormone replacement therapy. That question came right away in terms of years ago, take it, later, don't take it. Now it's like, what's the take on HRTs?
Yes. So for women that don't have significant risk factors, if we start hormone replacement therapy within the first 10 years of menopause, it can be really beneficial. So we know that the main reason for hormone replacement therapy is for what we call vasomotor symptoms, or just making sure you can hear me, or hot flashes. So it's really our primary reason for hormone replacement therapy. We also use it for patients that have low bone mass. So it's really targeted for those specific populations. It did get a bad rap after there was a study, as Dr. Volkman had mentioned, but the study was very broad. And so now we know that there's a more narrow scope where there is safe and effective hormone replacement that we can give. So we typically don't start hormone replacement therapy for patients that are over 10 years away from menopause or over age 60. So those are our criteria. We know that that can increase the risk of cardiovascular disease if we started at later ages or further from menopause. So we avoid that. We also try to use hormone replacement therapy for the lowest dose that's effective for the patient and for the shortest time that we have benefit. So a lot of people do a few years out from menopause start to experience less symptoms. And so those are patients where we can decrease the dose of hormone replacement therapy or stop it altogether over time as your body kind of regulates to these new changes. So it is safe to use. We do review risk factors for patients. Kind of our biggest time that we wouldn't use it is someone that has a history of things like breast cancer, or a gynecologic cancer. Those are kind of our biggest times. Or someone that's had a clotting disorder or uncontrolled high blood pressure disease, significant cardiovascular disease. Those are patients we would be cautious in using it for. But outside of that, it actually might be beneficial for heart health for healthy women postmenopause, as long as we're using it in the appropriate person.
Yeah, I just want to add that I get a lot of patients from primary care physicians who refer them to me for if it's okay to use hormone replacement therapy. And I totally agree with what Dr. Drake said. I just want to point out that we never advocate that the use of hormone replacement therapy can decrease cardiovascular disease. We advocate using it to help with menopause symptoms. And so the studies that were done in the Women's Health Initiative was specifically one drug, Prempro, and estrogen alone in the patients who didn't have a uterus. So that was one drug. And now the gynecologists and primary care physicians have a whole array of different kinds of dosing and ways to give it. So please, if you're a woman who is suffering from menopausal symptoms, there is help for you, and you will not be upsetting your cardiologist if you want to try those. You don't have to see a cardiologist if you don't have any cardiovascular disease and you want to use hormone replacement therapy. You don't need to see a cardiologist.
I'm so glad you mentioned that, because the other point is, oh, go ahead, Dr.
No,
Torkelson.
finish what you're saying.
The other comment that that came through was that, and actually in my case, if the symptom is hot flashes, I mean they are bothersome. Some people will say, okay, but not only the symptoms, but are they to the point that you really need something? And at times it's not the hot flashes, at times it's the mood swings, so there was something about that in terms of for what symptoms. And I guess that the answer is, well, for those that are very problematic to you.
Yeah, so it really depends a lot on your lifestyle and how much it impacts your lifestyle and the severity. There are other lifestyle changes that we do recommend. So regular cardiovascular exercise is important, healthy diet, decreasing carbohydrates and alcohol. Those can always have an effect and improve, especially people notice they have their glass of red wine at night and they have significant hot flashes afterwards. So making some of those lifestyle changes can be helpful. And there are non-hormonal medications that we have as well. And so discussing with your provider, what your symptoms are and what your goals of treatment are can be helpful for us to guide you in the right direction and to you use something that's going to be beneficial, but also limit risk for you. So there's other options.
All right, I'm going to be a party pooper here. I'm glad you talked about wine. So wine was initially thought was heart healthy, and I think that we need to just make sure that people know it is not as heart healthy as we thought it was. It does lead, I always caution my patients who are having palpitations that if they're drinking wine, they are going to put themselves at risk for atrial fibrillation, which can lead to strokes in the future. So you really should never use wine or alcohol to decrease your risk of heart disease. If you really like wine, drink a little bit. For men, it's 2 servings of alcohol, and for women, less than 1 serving would be okay. That probably will not lead to untoward effects. But remember that wine can also lead to different kinds of cancers, especially breast cancer. So that's why women who have had breast cancer are advised not to drink any more alcohol because it can increase the risk.
Great point. Is it because of the sugar?
Don't know. It may be more than the sugar.
I just
Go
wanted
ahead.
to make the point about maybe some around hormone therapy and separating out systemic use from local vaginal use, because there are many people who may not decide to do systemic estrogen either through transdermal or oral, but they may, if they need it for vaginal dryness, which many postmenopausal women really find it necessary and often hard to talk about with their physician, and even for sometimes a reduction of UTIs, chronic UTIs can be helpful. So I think that separating out the systemic from the vaginal or topical, vaginal is real important.
Mhm.
Great point, Carolyn. Thank you.
I'm glad you added that. Yes, yes. Okay, so let's see. Another question in terms of the yearly gynecologic visits, we talked about postmenopause. Does that change perimenopause as well? Or is the same?
It's the same recommendation. So we do recommend a yearly gynecologic visit. It really depends on what kind of symptoms you have. So that yearly gynecologic visit should just be that check-in, that health maintenance visit. But if you're experiencing more symptoms of perimenopause, that's where you need to see more frequently as you're experiencing those symptoms, that we can discuss, is this the time that we need to make some lifestyle changes or medication changes? Typically, when you're perimenopausal, we don't recommend hormone replacement therapy. We actually recommend, if we're going to do hormonal management, that we do the same medications we would do for things like birth control, because your body's making a different type of estrogen at that time, and you still need potentially contraception if you're not fully menopausal. So it's a discussion to be had depending on your symptoms. So if you are more symptomatic, seeing someone more frequently than yearly is also recommended.
Great. And in our audience, we have a 70 years old woman. I'm over 70 years old and just need clarification regarding discontinuing pap smears. Am I hearing that it is safe to stop having them?
So I think I mentioned before, if you've had 10 years of normal pap smears and you're over age 65, then you can stop if you've never had a precancerous lesion on your cervix or a gynecologic cancer. If you have had any precancer of the cervix, then you need to be followed for at least 25 years after that last precancer of the cervix was treated. And so that might be over age 65, depending on what time that was diagnosed.
Wonderful. And this is a great thing when we record these lectures. You can go back and check all the facts and use it as a reference. Dr. Volkman, 45% of people with diabetes have higher risk to develop heart disease. Is that what you said?
No. So women who have diabetes
Okay.
has a 45% higher risk than a man. to develop heart disease. So if you're a diabetic, we basically assume that you're going to have heart disease. We just treat you as if you have heart disease because your risk of a heart attack is the same as somebody who's already had a heart attack of having a heart attack. So if you're a woman or a man over the age of 40 and you have been diagnosed with diabetes, we will start you on statins, not only to lower your cholesterol, but to stabilize any plaque and to decrease your risk of a heart attack and stroke and death from those. So I just want to make sure that women, especially women, if you're over 40, please let your doctor give you the statins. Don't try to persuade them that you don't want to take it because they're trying to save your life. They're trying to decrease your risk of a heart attack and stroke by giving those cholesterol medications. I don't even call them cholesterol medications anymore. I don't say I'm going to lower your cholesterol. I'm going to say I tell them that I'm going to decrease your risk of a heart attack and stroke. And they usually say, "Oh yeah, let me take that." It's just a matter of how you frame it and how you tell your patients what you're trying to do. Because if you want to just decrease cholesterol and it has no consequence, why would they want to do it?
Yes.
If there are any professional people out there, providers, please be aggressive, especially with the women who have diabetes, because we're undertreating them. They're being mistreated by the healthcare system.
Yeah. Help me envision the future
Yes,
me.
exactly.
Okay, good. Okay. So the second part to that question is if that's the same for pre-diabetes.
It starts during the pre-diabetes. So yeah, we're going to be aggressive with those patients too.
All right. All right. So Dr. Turkenson and Dr. Marino, the self-care, when you spoke about the connecting with something larger than ourselves, I know you mentioned spirituality, which made me think of a lecture on spirituality that we're going to have very soon. So stay tuned for Rush Generation's upcoming events. But also, is it only spirituality? Because we have been hearing a lot about the connection with our creative selves or arts in general, how also that contributes to our well-being. Any thoughts on that? That larger thing? Is it only spirituality? I would say probably not, but.
Well, I think that many women would find that expressing themselves creatively is part of spirituality for many women. It's like spirituality is this broad umbrella, and being creative, whether it's through the arts or I like, people also talk about being creative in how you live your life and the design of your life. So it's lifestyle and it's being congruent between, your values and how you present yourself in the world. So thinking about creativity in a really broad sense.
And I like to emphasize that when we're talking about integrative care, holistic care, we're talking about mind, body, spirit, and that really that is really broad based. How we think, what we do, how we perform, what our spirituality, as Catherine said, can be how we function in the world. It can be united. It can be very regimented. I mean, there's spirituality that is really based in one of the traditions, or it can be very loose and universal. So we're speaking from a very broad perspective. What is unique to that particular individual?
The other thing that is interesting is the research that's been done on brain health, and that engaging in any kind of spiritual practice is also good for your brain. So it's that way of bringing together the mind and the brain.
Yeah, they're
Mhm.
linked.
I like that. So it doesn't have to be something. Go ahead, Dr. Bowman.
I was going to say, speaking of mind and brain, at the Rush Heart Center for Women, we have a cardiocognitive neurologist.
Oh,
Dr. Neelam Agarwal and I share a passion for the connection between cardiovascular disease and Alzheimer's or cognitive function. Because if you don't treat your cardiovascular disease, remember the blood vessels are all over the body, especially the brain. And if your blood vessels are not healthy, your brain can't be healthy. So we have a special place for Dr. Agarwal at the Rush Heart Center for Women, so that a lot of my patients who complain of cognitive problems, they're starting to be more forgetful. They worry that they're starting to get dementia. I immediately send them to Dr. Agarwal to get tested. And we unfortunately have diagnosed a cognitive dysfunction in a lot of our patients. And so we're working with them to make sure that they are getting aggressive treatment for their cardiovascular disease, and that they know, what to expect. And she works with them. We have studies that we conduct at the Rush Heart Center for Women for these patients, and we're about to do a really cool study with technology where you don't need a special neurologist to identify the nuances of somebody who's starting to get cognitive decline. You can just answer questions, and AI will figure out the way you respond to the question may be a sign of cognitive decline. So it's really cool. I'm really excited that we're going to be doing that.
great.
That is fantastic. You're also making me think about, studies that I don't know if that's available, but it would be nice to also know of or evaluating individuals that probably reach their later years, but without necessarily, having those type of complications. So what in their lifestyle is it that is contributing to that? So not only when there's some disease or symptoms. Thank you, Hannah, for letting me know. There's another question in terms of the preeclampsia relation to diabetes, not gestational diabetes. I think that you explained that, Dr. Bowman, right?
Yeah, gestational diabetes, specifically diabetes that occurs during pregnancy, and women, unfortunately, are at risk of developing diabetes in the future when they get to diabetes. So anyone who develops gestational diabetes should be followed up by their primary care physician for that risk. The statistics is that 70% of those women who get gestational diabetes will get diabetes over the next 30 years. So you have a long time to prevent diabetes by eating healthy and exercising and doing all the, heart healthy things that we talk about all the time.
One more question. What is the heart damage that you get from breast cancer radiation?
Yes, unfortunately, if you get especially left-sided breast cancer, if you need radiation treatment, the breast cancer radiologists here at Rush created a way that you are prone on the table so that your heart and your lungs are out of the way when they do the radiation. And that should really be the way everyone does it, if at all possible. But if you do get irradiated through the chest, if it's on the left side, unfortunately the heart is right there, and it can create premature coronary artery disease, valve stiffness. So different kinds of heart disease can occur as a result of that treatment. So you should be followed by a cardiologist if you've had that kind of treatment.
Thank you for that. We are approaching the end. This is fascinating. I want to continue going, but I know not only that you have clinics and patients to attend to, but also, we want to encourage people. If you would like to expand on one of the concepts that was discussed here, let us know. We have the Rush Generation's email, or you can call our toll-free number. We can do that as well. We always hearing about what are the needs and some of the topics that are of interest to you. But before we wrap up, I'm just very tempted, since Dr. Torkelson and Dr. Marino talk about self-compassion, how self-compassion is key as we navigate our different life stages. Although I like the framework of health span. What are some of the ways that you do that? Self-compassion to any one of you. Self-compassion, how do you practice that?
Well, I could just mention that one thing around self-compassion is that many women I've found in practice are really hard on themselves. And they have really a lot of fixed messages about what they have or haven't done in their lives, or maybe even regrets. And I really think that's where self-compassion comes into play, while giving you permission to love yourself, giving and even reframing some of the concepts that you have in your mind. And that's where mindfulness practices can really come in. That can be very valuable, where you really can let go of some of that negative thinking in your head and really turn it into much more positive, constructive thoughts about the value of your life and how you've really had an impact on many people as you go through life. And that's what I see as self-compassion. And sometimes that drawing attention to women, that their thoughts are even there with them. Sometimes women don't even realize what's going on in their thinking pattern. So reframing that can be very helpful. But open to other ideas on self-compassion. But that's how I see it, and that's been my experience with a lot of women.
Thank you. Anyone else?
Well, Carolyn knows me very well, and she knows that I have had a long history of avoiding listening to my body. So that is definitely my one of my key where I put my attention. But the other is, I think what you asked, somebody asked about creativity, and I do a lot of mind work, and I sold my piano when I moved out of my home to a condo, and I've been missing it dearly. So I just bought an electric keyboard, came yesterday, set it up, and I'm plunking away. And it is a joyful experience, even though I'm, struggling with trying to remember how to read that music. But it's those kinds of things. What gives you pleasure? I think we just don't attend enough to pleasure.
Lovely. Dr. Drake? I think you're trying to unmute.
There we go. My screen was being a little tricky. No, I think all of those suggestions are fantastic. One thing, and I talked to my coworkers about it, so I'm definitely in that perimenopause time frame and feeling some of those symptoms and all of that. And I think some of it is just, giving yourself that grace, giving yourself like, this is the phase of life that I'm in, and knowing that it's going to be different than maybe life was a few years ago, and that you need to make those adjustments, but also know that you can't expect the same outcomes from a different phase of life. And so trying to meet yourself where you are, I think, is important. Definitely taking those times to enjoy life, taking moments out of life just to breathe and find times to make calm space. And there's, with technology, there's a whole bunch of new apps and videos and things like that can even guide you through some like short meditations. Definitely like the Calm app, even Spotify, the music app has some things within that app that you can do, short meditations, calming music, things like that to help you get through the day.
Thank you so much. So we have you at times, but before we wrap up, I want to leave everyone with this quote from Dr. Bowman. Don't forget to take care of your heart. And that is particularly important for those of you who are caring with someone. We have family caregiving duties, and many times we neglect ourselves. So show yourself some self-compassion and give yourself permission to at times take a break so that you are better equipped to continuing doing that great work. Thank you, ladies. This has been a wonderful women's panel. And thank you, Hannah, again for producing this wonderful lecture. And I just would love to have you at one point back again. But we greatly appreciate your time with us today.
Thank you.
Thank you so much.
Thank you to all of you. Let's see, let me go. Thank you, Hannah, for putting the slideshow. I'm so sorry, I'm trying to find let's see. Aha, thank you. I got it. What is coming next. Thank you so much. All right. So one of the things that we're going to be offering rather soon, it's another session for the art for emotional wellness that we're currently offering is coming back by popular demand. This is a free 4-week wellness class that incorporates various forms of art and expression to foster emotional wellness. And the program is designed and implemented by arts in healthcare students at Columbia College for their senior capstone project. Therefore, the topics and the mediums are going to change from year to year, but they can include fine arts, dance and movement, music, improv, poetry, and others. So we hope that you join us. It's going to be offered in person at our main Rush campus starting on Thursdays from April 3rd to April 24th. It's in the morning, 2 hours. Please feel free to give us a call at 1-800-757-0202 to register. Then we are going to offer a evidence-based program called Wellness Recovery Action Plan, or WRAP. It's a free program also for adults to learn skills that to get well and stay well and to make life more enjoyable. This workshop will teach participants to develop a daily wellness plan, discover simple and safe strategies, and create plans for responding to stress, negative thoughts, which we just discussed, and challenging times. This group meets once per week for 6 weeks and is an hour and a half. And the next workshop is going to be held in person again, April 14th through June 9th, from 1 p.m. to 3 p.m. Maybe it's 2:30 because it's 1.5 hours, but nevertheless, give us a call, 1-800-757-0202 for more information and or register. Then we also offer an enhanced walking program, which is through the Arthritis Foundation called Walk with Ease, where participants meet 3 times a week. And we do it also in collaboration with the beautiful Garfield Park Conservatory, very close to our campus. We do this with a certified Walk with Ease facilitator. They walk together. You get to walk at your own pace, but we form groups. And the walks can range from 10 minutes to 45 minutes. So individuals that are living with chronic arthritis, with arthritis or osteoporosis or chronic pain and other conditions are encouraged to participate. You do not need to have a health condition to participate. So anyone who wants to connect with others and become more active is welcome to join. It's going to be offered on Wednesdays, Thursdays, and Fridays, 3 days in a row, starting on April 30th. So give us a call if you would like to sign up. Shaman Senior Voices offers, aims to empower older adults to discuss what matters most to them as they age. So if you would like to share what matters most to you with your loved ones or your physicians, this is a great way of recording a video that you get to keep. We want to hear from you. So consider sharing that wisdom on why it is important for your healthcare team and your loved ones to know your health goals and your wishes and what matters most to you by going to our website. You can scan that QR code to record from a mobile device, from your laptop, a smartphone, you name it. So we want to learn from you. And as I mentioned, spirituality and aging, embracing everyday miracles. That's our next lecture, which is going to be on April 2nd. And this one is at 12 p.m. This is going to be a hybrid event. Some of you can join us in person, but you also will get to see us via our YouTube channel. If you are interested in this topic, please feel free to join us. There's limited registration for the in-person, so please give us a call, 1-800-757-0202. Thank you so much for joining us today. As we said earlier, if you would like to let us know about topics you would like to hear about, feel free to give us a call at 1-800-757-0202, or you can also make sure to write to us at rush_generations@rush.edu, or you can get in touch with us through our Facebook page. So thank you, everyone. We hope you have a great day.